Good afternoon, everyone. My name is Mayra Reiter. I am Health Programs Coordinator with Farmworker Justice. Our other panelists today are Dr. Laszlo Madaras, Chief Medical Officer with Migrant Clinicians Network, Patricia Avila-Garcia, Project Manager with Health Outreach Partners, and Hansel Ibarra, Program Director with MHP Salud. Today, Dr. Madaras will be discussing strategies and challenges in addressing opioid misuse for agricultural workers, while I will give an overview and summary of the results of the opioid use assessment carried out by the Farmworker Health Network in 2019. And my colleagues, Patty and Hansel, will talk about the reasons for opioid misuse among agricultural workers and health center training needs, respectively. This will be followed by time for questions. Our objectives today are to gain a better understanding of the trends and reasons for opioid misuse among agricultural workers, as well as strategies to address this problem and the needs of health centers that are working on this issue. I will now hand it over to Dr. Madaras, who will discuss strategies and challenges to address opioid misuse.
Okay, great. Thank you very much. Can you all hear me? Are we good? Okay, good. Well, thank you for inviting me. I'm very honored to be here. My name is Laszlo Madaras, and I am a family physician, board certified. I've been working as the Chief Medical Officer for Migrant Clinicians Network for the last several years. I'm also a community doctor who in the last 25 years has been working in South Central Pennsylvania with the agricultural community there. And working as a rural family physician, I have many hats. That also includes taking care of my patients while they're hospitalized as a hospitalist, and sometimes in the intensive care unit as they're withdrawing from certain substances. So I have the last 25 years done both outpatient and inpatient medicine, and I've really enjoyed working with my farm worker communities in this part of the United States. So I come with some level of experience. I'm not a pain management specialist, but as a family physician over the last 25 years, I feel like I have an insight at least into agricultural workers and the difficulties that they have sometimes with pain control. So I'm going to go here and Mayra, I think you're going to be moving the slides for me. Okay, great. Thank you. So pain is something that clinicians have been trying to help patients with for centuries, if not millennia. And Dr. Albert Schweitzer had said that pain is a more terrible lord over mankind than even death itself. And we've been able to use different types of medications, mostly herbal types of medications for many centuries. And in most recent couple of hundred years, we've been able to synthesize some more specific pain medications, which have tremendous benefits, but also tremendous side effects and consequences. So next slide here. So it's important to know that over the centuries, most drugs that are potential drugs of abuse are not new. They've been around with us for many years. So next slide again. So historical uses, cocaine from the cacao plant in Peru, for example, has been used to help aid tooth pain and toothaches in children. If you fly into Cusco in Peru, up at 13,000 feet at the airport, you're greeted with a lovely tea. And that is, again, the coca plant making a tea that you could drink there, which helps you energize and also helps a little bit with altitude discomforts. And it's been used traditionally by people in Peru, just chewing on the leaves. And in some ways, it acts just like coffee does in other cultures. It gets you a little bit more energy, makes you feel good and able to work. Heroin is a synthesized morphine that has been used in a previous century for cough, for example. And then the poppy seed, the lovely flowers of the poppy plant, you can see there in red. So next slide. So these have all been available over many centuries. In the United States, we have certain plants, derivatives like amphetamines, marijuana, and oxycodone that are legal, and they are used with a doctor's prescription. So these are available in the United States, but require some kind of prescription. So amphetamines have been used as a stimulant, such as Ritalin and Adderall for children with ADHD and other situations that are also using amphetamines in a medicinal way. Marijuana, which is legal in some states, but not all states. And then pain relief from the OxyContin family of medications, the narcotic pain reliefs that are required to have a doctor's prescription to handle. Next slide. So other ones are legal that don't require any prescription at all, and that includes caffeine. I'm drinking a cup of coffee here right now as I talk to you, tobacco, and then alcohol. And some of these are very addicting. Some of them are moderately addicting, but withdrawing from them becomes very challenging. In fact, in the intensive care unit, withdrawing from alcohol is probably the most deadly or life-threatening situation that I encounter working in the intensive care unit. And so alcohol, while it's legal and it has a moderate addicting capacity, it has a very severe withdrawal consequence. Next slide. So getting to the opium plant, which is where the conversation is going to go from here. Opium is a dried latex secretion of the poppy plant. And it is basically a natural pesticide that keeps bugs from bothering the seed form before it becomes the flower form. And 2% of that dried latex is made of codeine and 10% in morphine. Now, about 200 years ago, a German chemist in 1804 synthesized morphine, and that then became a very powerful source of pain medication for the medical community. It has many uses even today, and morphine is named after the Greek god of dreams, Morpheus, because in higher doses, it can put you to sleep. It does many other things that are beneficial, and then many other things that are very harmful. It has an addicting capacity as well. About 100 years later, in 1898, heroin was synthesized, and it's a synthetic morphine. It was originally thought to be non-addicting, and it's sold by Bayer Pharmaceuticals. For about 10 years, it was being used in all sorts of things that, like tooth pain and cough, before the harmful effects were recognized. It is more powerful than morphine. When it's injected, it passes through the body and then gets turned into morphine, and it's delivered directly into target organs. So that makes it even more powerful than just morphine being ingested. And then next slide. So the things that are not legal in the United States include cocaine, but again, in Peru, the leaves are chewed, and in many other nearby countries, it is used medicinally. Cocaine is actually a dopamine reuptake inhibitor. And so it gives you a certain kind of feeling that in smaller doses, it feels good, but doesn't give you a great high unless it's in a more concentrated form. But we won't talk about much of cocaine as we're talking about opioids here. Heroin is also used in some countries to treat heroin addiction. So in some places, trying to withdraw from heroin requires a doctor to write a prescription for you for low doses of heroin, so you don't withdraw by having none, and you don't overdose by having too much. And there are needle exchange programs in different cities to try to prevent the effect of heroin on being injected and causing infectious diseases when they're dirty needles. So this is a great way to prevent HIV from spreading and hepatitis C and other bloodborne infections. Also not legal in the United States is methamphetamines. So the amphetamines that we give, the Ritalin and the Adderall, amphetamine-like drugs, are being synthesized with a different methyl group on them. And when you have that, it is allowed then to transport the amphetamine across the blood-brain barrier and get into your system much quicker, and therefore the addicting and the high that methamphetamines give. Next. So all of these are psychoactive drugs, and what these do is affect the function of the brain, produce a psychological effect. It changes mood, perception, behavior, cognition. It's often addicting, but not always. And again, these included what I mentioned: caffeine, nicotine, alcohol, cocaine, and heroin, the synthetic morphine. Again, the Ritalin, Adderall. So these are the amphetamines that can be very psychoactive. And some of these can be used, and you don't necessarily become addicted to them if you can be under a supervised condition. But there's also a great chance of abuse, and that's been happening with all these different drugs, including the opiates. Next slide, please. So now I'm going to focus on the opioids. And I mentioned that morphine was synthesized in the 1800s, early 1800s, and heroin 100 years later. And then 100 years after that, in 1996, we had the first formulation by Purdue Pharma of OxyContin. This happened in 1996, just as I was finishing my residency. And so I've been with the transformation of this certain opioid that has caused so much problem in the United States and across the world for the last 25 years. And OxyContin is a synthetic sustained oxycodone preparation that was marked originally as less addicting than other opioids. And that turned out not to be true. So it's not as benign. And people started to use it for pain control and then developed this feeling of pleasure from it that they wanted to continue even after the original bodily injury had stopped. And that's why we have the situation we have currently, which I'll be talking about here. So opioids, next slide. I'm going to spend a little time on this slide here. So this is a neuron that is a transmitting neuron in the top, and the receiving neuron is at the bottom. So what happens when there's conduction of information from one nerve to another, it goes through these neurons on a long channel, and it can help prevent pain. It can also cause euphoria. It can cause various things depending on what part of the body you're talking about. But the important thing to remember here is that these little oranges that you see, that's dopamine. And dopamine is the major pathway for both pleasure, pain control, and addiction. There are many other kind of chemicals in the body, like serotonin, and we use serotonin medications, serotonin reuptake medications like Prozac and Paxil for antidepressive medications. Dopamine is the medication. The cocaine is a medication that is used to prevent dopamine from being taken up into the transmitting neuron again. So what happens is that the transmitting neuron sends down these little packets, what look like oranges here. They release them, they send them to the receiving neuron, and those little green areas that they sit on are the dopamine receptors. Once you get sufficient dopamine receptors with dopamine sitting on them, they activate and they send a message further down, going off the slide to the bottom. And that message then gets relayed as either pain prevention or some kind of euphoria, or even other kinds of things that the nervous system does. But you have the dopamine out in this environment, and if you have more of them, or if you have a reuptake inhibitor like cocaine, then they sit around a lot longer to do the things that they do, which can cause a tremendous increase in pleasure. And so once you receive that kind of pleasure, you have the pain control, but you're also remembering that this is very pleasurable, and you may want to have this experience again and again. So what opioids do is they take this transmitting neuron and they force the neuron to make more and more dopamine. And the body, however, does not want to have this larger amount of dopamine, so it sends a chemical to try to stop the dopamine from being produced in greater and greater amounts. It also tries to make the receiving neuron not have as much ability. It increases their threshold for firing. And so the body is trying to fight this in the homeostasis, whereas the opioid is trying to make more and more dopamine. And this battle becomes such that the first high that an addict will have is much stronger than all the next ones, the fourth one, the fifth one, the sixth one, because the body is now trying to fight this and reduce the number of dopamines that is available. So this is the biochemical, neurochemical basis for a lot of what we have as pain prevention, pleasure, and addiction and craving. I'll go over those terms shortly. And what we found over the last few years is that we don't actually even have to have a chemical in the body to have the dopamine start to be released. You can just look at something that will trigger the desire to use that substance because the dopamine is already being secreted even before you start using. So if somebody had used cocaine or heroin, seeing a needle or seeing the paraphernalia. Can you guys still hear me?
Yes.
You can still hear me. Okay, I just lost the slides here. Hang on a second. Okay, sorry about that.
It's okay.
I'm back here. Okay. So I don't want to dwell too much on this, but this is an important concept for those kind of things like addiction and what opioids actually do. One other point I want to make on this, and I won't belabor this any longer, is that there are certain kinds of receptors that we've just found in the last couple of years for some people. There's a genetic marker called the dopamine receptor D2, BRD2. And when this is very prevalent in people who have a strong predilection for addiction. We don't know how much of the population actually has this gene, but if you do have this gene, you need more stimulation to get the same kind of feeling that a person not having this gene will have just on an ordinary day. And so one of the theories is that the people who are more likely to have this DRD2 gene will need more stimulation and will need either substances. This actually goes into addiction to things like gambling and video games and other things as well. But if you have that receptor variant, then you may be more prone to addiction. And it may be that these are the people we have to be very concerned about if we give them opioids for some kind of pain, because there's a subgroup that will then want to have this over and over again. And this may be at least partially a genetic component. So we're learning more and more about this over the last 10 years or so. All right, next slide. I won't belabor this one because we just talked about this on the other slide, but the dopamine pathway is going to be all sorts of things between amphetamines and even coffee and the adrenal system and the dopamine system are the common pathway for so many of these different drugs of addiction potential. Next slide. So what causes addiction? Poor choices, bad parenting, weak character, none of these. And I'd really like you to keep in mind this genetic component that we're studying more and more. So the answer is no, not poor choices, not bad parenting, not weak character. Next slide. So brain physiology. So what is actually happening is that with opioids in brain physiology, on the larger sense, is the opioid family is narcotic analgesics. And what they do is they reduce pain without reducing sensation. So you can be active and you can still be at work and functional, but your pain reduction is tremendous. This is in contrast to anesthesias, anesthetics, which reduce pain, but also reduce other sensations and can often put you to sleep. So a narcotic analgesic functions in a great way that you can continue doing your work, be pain-free, and it seems like you have no consequences except that you develop a dependence on it. It also gives you a dreamlike euphoria. And so for some people who are attracted or are like recreational drug users and who may have this DRD2 gene, it's very appealing for that euphoric state. It also reduces the cough reflex. So we still use that, the Tylenol codeine, we still use that to reduce the cough reflex. But heavy doses of these narcotics will stop your breathing. And that's how many addicts have died, is that they've overdosed and their breathing simply stops. In lesser doses, we also use this to prevent air hunger in patients who are dying, who are cancer patients, let's say, at the end of their lives. So it is still important. I don't want to say that this is not a good medication. It is just that it has such high abuse potential. But the narcotics, including morphine, are given at the end of life to help with air hunger as well. So it has a complex brain chemistry. And when people get used to it, they need more and more of it. Remember that pathway where the brain is trying to shut it down a little bit, and you need more and more of the drug to get that same high feeling. And when that happens and you don't get the drug anymore, you go through withdrawals. And withdrawal is that the mirror opposite of of what happens when you take the medication. So instead of feeling euphoric, you feel paranoid and anxious. And instead of pain control, you have a great deal of joint pains and all sorts of different difficulties. And also, the opioids have an effect on the GI system. And if you take too much, you're constipated. If you're in withdrawal, the mirror opposite happens, and you're starting to have very loose stools. So a lot of times when I see patients in the hospital who have diarrhea, massive diarrhea, who don't have infections, I'm worried that they have opioid withdrawal. And so I often bring them into the intensive care unit because I'm worried that they may be withdrawing, given that they have massive diarrhea that I can't explain it any other way. Okay. Next slide. So what happens is that we have these dopamine receptors in the brain, and we have morphine seems to stimulate them. But these are something outside your body. These are poppy plants. So why do we have that? The answer is that our own brain makes endogenous morphine. And we can see that in sort of the runner's high. So you can be getting a kind of a morphine injection from your own brain. And these endogenous morphines are called endorphins. Your body makes them in small amounts, but they are the same receptors that the opioids use to give you that super high feeling. And you can see this also in war combatants. When they are wounded, for the first couple of minutes when they're in the heat of battle, they don't feel a lot of pain. They'll tell you later on they didn't feel pain at that time. And that's because their endogenous morphine system gave them that feeling of no pain. It blocked pain. So there is some benefit to that. And you can get addicted, runners can get addicted to running long distances. So it can be addicting. Is it unhealthy? Next slide. So instead of using addiction now, we say for people who use substances that they have a substance use disorder. And that this is a disorder when it's unhealthy. That's the preferred medical terminology. Next slide. So it's abuse when it has unhealthy consequences and that there is harm done. Dependence is when you have a psychological or a physical tolerance, when now you really want to be using the drug and you still need to use it, even if, for example, you have no pain, but you still need the drug to make you feel better. Next slide. And then there's craving. So craving is the feeling that, again, when you see the pipe that you used to do crack cocaine, or you see the restaurant that you used to go to have cigarettes, or any of these other kinds of things that are triggers, dopamine is already starting to be released in your system, and you crave now to get more of that and to get to that high. So craving is when you're not using, but you can't think of anything else that you really want to use that drug once again. Yeah, that's fine. So tolerance is when the brain expects the drug and really wants to keep using it. And your body, again, is trying to shut it down a little bit more, and you need higher and higher levels. Once you can't get that, you get to the withdrawal stage. And that's when, again, I talked about having in the case of opioids anyway, the mirror image of what the pleasure feeling and the pain control feeling you get from the opioids. So withdrawal is when suddenly you don't have the ability to get the narcotic, and your body goes through withdrawal where it really craves the drug, and you start to feel really bad, paranoid. Now you're, instead of constipation, you have diarrhea, and you get very anxious, and everything hurts. And you do get through that, but it's very difficult. And then the last thing I want to mention on this is that if the addiction is so strong that you go back to it eventually, and you've gotten off the medication altogether, and suddenly you start taking it again, you can overdose with the same level that you thought you needed, because that's the highest dose that you had when you finished. So if you come back to that again in that high level, it's going to be too high for your body because your homeostasis has downgraded all the receptors. You're not ready to take on such a large dose again, and your body will overdose, even though you think that was just exactly what you were on a year and a half ago when you took that opioid last time around. So this is what makes it so deadly as well. And a lot of times addicts will die as they go back to their first hit after being off for a long time. Okay, next slide. So injuries at work. So we're going to get off the neurochemistry part here just a minute or two on injuries at work. So farm working is very dangerous. It requires you to be out using your body, using equipment that could be dangerous. And next slide. Common causes of these kind of injuries is lifting, bending over. You can fall from ladders, carrying heavy objects in ways that torque your back, and reaching high. Next slide. Yeah, we can keep going on these. These are just incidents of farm working accidents that often lead to death. And so, yes, it can lead to death. It's very challenging to be doing this kind of hard work. I have total respect for our farming communities for this reason. They work very hard, so they can die, but they also can be not killed but injured, maimed or just incapacitated in some way. Next slide. And the challenge is, if you have these injuries and you're, say, a migrant farm worker, you don't get paid unless you work. And even if you have something in a contract that says you have some disability or time off for injury, you may not even know about that. And you may not be aware that you have certain rights. But these are the kinds of repetitive motion disorders and uncomfortable postures, which may lead to the type of injury where you would normally be incapacitated. But now you have the choice of having opioids, and you use them to help prevent the pain. And then a subpopulation of that group will get this feeling of euphoria that they really want to keep doing this drug for longer periods of time than is necessary for the actual injury that was sustained. On the other hand, if you don't get any time off, you may have a chronic injury that you can't give yourself enough time to recover from, and then you're using the opioid longer and longer for reasons that still relate to body injury. Next slide. Almost done here now. So opioids in work. So you do have this really challenging work, and you're working on staying employed, and so the temptation is to continue using opioids at work. Next slide. Cultural dimensions of pain. And there's some places in the world where you don't have the option of having a lot of pain control. So some people just get used to the idea of pain is just a natural part of their day. It doesn't mean that genetically they're more prone to tolerate pain necessarily, but they may just be culturally not expecting to have total control of all their pain. But it's very complicated. The cultural dimensions of pain is an entire other webinar that we can get into that MCN has. Next slide. And pain is subjective. It's a subjective phenomenon that often defies objective medical assessment, particularly susceptible to social, psychological influences such as stereotypes. And it is something we can't really measure well. So we depend on the patient to tell us what kind of pain they have. Next slide. So what do we want? Ultimately, we want to bridge the patient's goals with medical options that we have, address all the aspects of their pain, their suffering, including physical, emotional, spiritual, and social. Next slide. Want to maximize their quality of life, assist in their search for meaning. Next slide. So there's disparities in pain also, and there's different approaches. And in experiential research, they've found that there's some age differences, race, sex, and ethnic differences in people's expectation of pain and their response to it. Next slide. Sorry. So there's gender roles also. And for example, here, I do have a bias sometimes when I'm in the emergency room and I have a young man who's there saying he has 10 out of 10 pain. And his experience, his pain is the strongest it's ever been, and that's 10 out of 10. But then next door, I have a woman who has had 3 normal vaginal deliveries without using epidural medication. And they're 10. They say they have 10 out of 10 pain too. And if I know that somebody's had, delivered 3 babies and had no epidural anesthesia, I take that 10 as a different kind of 10 than that gentleman I just talked about who's never given birth. And so my expectations, their expectations may be different too. So this becomes very subjective and very challenging sometimes to figure out, when do you give and how strong medication you give for pain. Next. Yeah, and one's expectations of pain experiences another person are influenced by stereotypes one has about different genders, races, and ages. And then there are also racial and ethnic disparities in pain perception, assessment, and treatment. These are found in different settings, such as post-operative, and like I said, in the emergency room, across all types of pain, acute pain or chronic cancer pain, chronic non-malignant, and experimental. So the last thing I want to say is that there is medications, and I'm not going to go over this a whole lot at this point, but medication-assisted treatment is the use of medications such as buprenorphine, methadone, and extended-release naltrexone, often in combination with counseling, such as cognitive behavioral therapies. And these are used in conjunction to treat opioid use disorder. Unfortunately, nearly 80% of those with opioid use disorder do not receive treatment. Okay, next slide. So there it is. The use of medication-assisted treatment has been shown to increase recovery rates, decrease overdose death, decrease criminal activity, and lower the risk of infections such as HIV and hepatitis C. All right, and these are the guidelines for pain management. I won't go over many more of these. I think I'm getting to my time here. And I'm going to turn it over to my colleagues here next as to what we can do with this and the opioid assessment use for agricultural workers. So thank you very much. I'm sorry I had to speak kind of quickly, and I put together 3 days of medical school lectures into 20 minutes or so. So my apologies. And thank you for my interpreter for being patient with me.
Thank you, Dr. Madaras. I will now give you an overview of the opioid use assessment in agricultural worker communities that was carried out by the organizations that compose the Farmworker Health Network in 2019. So this assessment was done during the period of July through November 2019. And the purpose was to better understand what health service providers and other professionals that provide direct services to agricultural worker communities are observing regarding the extent of opioid misuse among these workers and their families, and also to identify training and technical assistance needs of health centers. The assessment consisted of 3 parts. First, an online survey that gathered information from 78 individuals, 68 of them health center staff serving these communities, and the remainder legal aid and community organizations and academic institutions. In-depth interviews with 9 individuals, 6 of whom were health center staff, 2 belonged to community-based organizations, and 1 belonged to an academic institution. In addition to that, focus groups were convened at the Midwest Stream Forum and East Coast Migrant Stream Forum in September and October of 2019. The first question we asked in the online survey was, are you seeing opioid misuse among the following populations in your community? And the respondents could select more than one answer. 84% of respondents said they were seeing opioid misuse in the general population, while 23% were seeing it among agricultural workers and 16% among agricultural worker families. We then asked, if applicable, when did you become aware of opioid misuse among these populations? Their options were during the current year, past 2 years, past 5 years, past 10 years, and not applicable. In the chart, the color blue represents the general population and yellow represents agricultural workers. Although respondents first became aware of opioid misuse among the general population, mostly between 5 and 10 years ago, awareness of opioid misuse among agricultural workers was more recent and gained mostly during the 2 years prior to the survey. We also asked, what have you observed as strategies used by agricultural workers to manage pain? Check all that apply. The 3 strategies mentioned the most were over-the-counter medications, mentioned by about 91% of respondents, alcohol, mentioned by 53%, and prescribed medications, mentioned by roughly 51%. Opioids belong in this category of prescribed medications, but the category also includes non-opioid prescription pain relievers. Other strategies observed were traditional healers, selected by 41%, massage by 24%, and marijuana products such as CBD by 20%. We also asked respondents to select from a list which issues they thought were high priority issues affecting their communities. Diabetes, hypertension, mental health, and occupational or environmental illnesses were selected as high priority by large majorities of respondents, ranging from 59% to 79%. Substance abuse, which includes alcohol and prescribed and illegal drugs, was chosen as a high priority by 42%. That is the orange column you see on the right. Opioid misuse, shown here in yellow, was chosen by 20%. These two categories of substance abuse and opioid misuse partially overlap. But based on these observations, it appears that opioid misuse does not rise to the same level of priority for most of the respondents as some of the other issues mentioned. But when 1 in 5 service providers rank it as a high priority, we need to make sure that they have the training and the tools they need at their disposal to address this problem. We asked respondents whether their organizations are working to address opioid misuse, and approximately 66% said yes. In the last question of the survey, we asked respondents which clinical opioid management strategies they had adapted for use with agricultural workers or other special populations. Just over half said their strategies included revising and implementing policies, patient agreements and workflows, and or tracking or monitoring patient care. About 48% had implemented patient-centered visits, and just about 33% were measuring implementation success. Now my colleague, Patty Avila-Garcia, will discuss some of the interview and focus group results concerning the reasons for opioid misuse.
Thank you, Mayra. So I will just be going over some of the reasons that were given in the survey and in the individual interviews for opioid misuse. And some of the things that were mentioned were using for self-medication, experiencing socioeconomic disadvantages, the ease of obtaining opioids from family, friends, emergency rooms, or in Mexico, dealers selling opioids in workplaces, experiencing occupational injuries, the overprescription of pain medication, and the shortage of providers to treat opioid misuse, and also because of stigma associated with addiction. Next slide. And here I want to zoom out for a moment and talk about what we can consider to be some of the root causes for opioid misuse among agricultural workers. And again, this is a largely understudied topic, specifically in the agricultural worker population, but we can begin to analyze some of the underlying causes and the different possible points of intervention. Dr. Madaras has already touched on many of these, so I will just summarize. And here I name 2 factors for each level. So one on the left side and the right side of this image, but likely there are many factors impacting opioid misuse. So we start at the top is what the level for behavioral or individual level factors near the surface of the roots. So the things that we can easily identify as immediate causes. And so one of them would be having access to opioids and opioid sharing. And this can happen within families, between friends, and among coworkers. And having more opioids prescribed than are necessary can also lead to people using for longer periods of time beyond what they were prescribed for. In addition, agricultural work ranks among the highest and most dangerous hazardous industry. So workers are at very high risk for fatal and non-fatal injuries and have repetitive motions and work in awkward positions. And again, they're, as mentioned before, they're at high risk for falls and injuries. Moving lower to the next level, health education. So having a lack of pain management strategies, opioids being one of the only options being used for managing pain. And then lack of health education and awareness of the proper use of opioids and their addiction risks. Opioid abuse can begin accidentally with the use of what might be deemed as a safe painkiller, especially if patients are not thoroughly consulted or educated on the risk of opioid addiction. And going down one more level, on the clinical level, we see how current clinical practices and resources available can factor in opioid use. So having a culture of overprescription of opioids to treat pain, being the only go-to solution without offering alternative pain management options like over-the-counter aspirin, ibuprofen, and non-drug remedies like physical therapy, massages, and acupuncture, or not developing safe pain management plans. And this overprescription is now being understood to happen systematically across the healthcare system and has been correlated with the opioid crisis. And having a shortage of behavioral and mental health specialists, there are evidence-based behavioral and medical treatments available to address opioid misuse. However, we are faced with the reality of longstanding provider shortages in health centers, and this includes the lack of health specialists, counselors, and other health professionals to help with addiction treatment, mental health, and pain management. On the healthcare system level, not having access to health insurance or being underinsured. As we know, there is still a need for health insurance coverage among the agricultural community. Of course, we know there's also intentional efforts to raise that number with work like the work of the Ag Worker Access Campaign. But as of the last National Ag Worker Survey, about 46% of respondents said that they had insurance coverage. And in addition to that, access does not ensure quality care, so there is still a barrier to quality healthcare services, including linguistically and culturally appropriate education. There are documented racial and ethnic disparities in pain treatment, which have been influenced by implicit biases and stereotypes that are held about groups of people. So having culturally competent staff and implicit bias trainings is really important. And finally, at the very bottom, we can see some of the socioeconomic factors that may create conditions for opioid misuse. So having socioeconomic stressors, including the conditions that agricultural workers are faced with, like working low-wage jobs, experiencing poverty, poor living conditions, and especially for those who are in the country alone, social isolation, as well as limited labor protections that make it likely that people will be overworked and experience abuse in the workplace. There are also larger social issues of stigma of opioid abuse and addiction, and the idea that addiction is due to the lack of willpower instead of acknowledging it as a disease. And so this can impact people's decision to identify and admit to opioid misuse and seek help. And the stigma can lead to fear about what might happen with your job or legal status if you do seek help. And all this to say is that there are many contributing factors for opioid misuse that require many levels of intervention for the agricultural worker population. And so now I will hand it over to my colleague Hansel, who will share about some of the strategies for addressing opioid misuse.
Thank you, Patty. So what works? So as we know today, we have learned different causes for opioid misuse, which is stress, stigmas, work injuries, etc., how addictions work and their effects on the human brains, barriers to service, misinformation, and social stigmas around the subject, lead individuals to deal with the situation independently and not look for help. Accepting assistance may lead to being judged or worse, being shunned by your family. The best way to combat opioid misuse in our communities is through education. Knowledge is power. Most people are not aware of how opioids work, their dangers, or how to treat it. Opioids misuse is viewed in some communities as moral failings. They're not aware of the chronic pain the individuals may be going through. Next slide, please. So the role of a CHW, the CHW would be your community health worker. So underserved communities that experience health barriers are often at greater risk of misusing opioids and rejecting or not being able to be aware of available assistance. This can be due to the lack of culturally appropriate material, the lack of support groups, or maybe there's a gap between those in need and the available resources. The community health worker, or also known as promotores de salud or outreach workers, role in addressing opioid misuse among agricultural worker community is to educate them on the subject, provide support to those suffering from opioid abuse and their loved ones, and act as a bridge between those that are between the affected individuals and the available resources. A community health worker is a frontline public health worker who is a trusted member or has an unusually close understanding of the community they serve. This trusting relationship enables the worker to serve as a liaison, as a link, an intermediary between health and social services and the community to facilitate access to services and improve the quality of cultural competency, of services delivered. We say trusted member of the community since most of the time the CHW are from the same community they serve, speaking the same language, and most of the time sharing the same beliefs, or at least understanding those beliefs. So how does the CHW accomplish this? What is their role in reaching out to the community? As I mentioned, they would be disseminating information, so that can be in the source of maybe handouts or flyers. They also provide support, and this can be through group sessions or presentations. And they also provide, or they also offer resources. So the CHW are most of the time aware of possible resources available and the requirements and the locations of where they can go to this. Next slide, please. All right, so addressing misuse through educational material. So one of the things that the community health worker addresses, or a way that the community health worker addresses opioid misuse, is by conducting outreach and educating the community on the same issue. They are usually from the community, like I mentioned earlier, which allows them to provide culturally appropriate information. This can be in the form of culturally and literacy level appropriate handouts, flyers, or through classes, gatherings, or talks. Another way that the CHW can go ahead and provide educational material, or a benefit of providing educational material, is that through education you can combat stigmas. Misinformation can lead people to believe that things might not be truth. Educating the community on the subject of opioids will allow them to distinguish rumors and stigmas versus the facts. Making the community aware of the problem will promote empathy, which will allow them to place themselves in that individual's position. By them being able to place themselves in that individual's position, we encourage or allow for progress to take place. Because CHWs speak the same language as those that they serve, it allows communities who face language barriers the path to express their opioid concerns without fear of being misinterpreted. The community can engage in dialogue and express their concerns in a safe place. And this safe place can be either at a church, at a home, at a community center, at a school, so anywhere where they might feel comfortable. People are more likely to seek help when they know the dangers and better understand the issue. Seeking help in early stages leads to better health in the long term. And another thing that the CHW can go ahead and do is they can provide alternatives. They can provide alternatives for self-managing that pain. As we have learned, some of these individuals do have chronic pain. Some of these individuals continue using opioids because they don't have that time to deal with that pain. So a CHW can go ahead and provide you some activities, stretches, to go ahead and help you maybe overcome those pains. Next slide, please. Another thing that they go ahead and do is provide support. And like I mentioned, this support can be through group sessions or through an outreach. In the clinical aspect, the CHWs can provide auxiliary support for opioid treatment delivery through case management and the promotion of patient adherence to the treatment. In group visits, patients with similar chronic diseases, in this case, opioid misuse, are seen as a group because patients living with chronic disease often feel a sense of shame and isolation. Bringing individuals together in a protective and safe space can potentially create a healing community where members develop connections to others with similar conditions, learn from each other, and gain a sense of validation and a hope for recovery. An interesting fact, a study conducted by the Washington State Institute for Public Policy, they found a return on investment of $1.25 for every dollar that they spent on peer delivery substance abuse programs, demonstrating that community health workers are a strong addition to patient care teams that can possibly influence outcomes for individuals with opioid misuse. Another thing that the CHW can go ahead and provide support is through translating and explaining the material. Sometimes as individuals, they get medication that they might not fully comprehend. And this is where the CHW can go ahead and help. They can go ahead and read the medication and translate to them the instructions that the doctor has issued. And they can also ensure that they are following those instructions as well. As we had also mentioned earlier, there is a shortage on medical and professionals. A CHW can go ahead and assist with this. According to HRSA, there is a projected shortage by 2025 of psychiatrists, clinical counselors, substance abuse social workers, school counselors, and marriage and family therapists, with low numbers of doctors and psychiatrists using CHWs to screen for mental health illnesses or opioid abuse can be the answer. They can work as frontline to the doctors and screen patients and distinguish those with high levels and those with low levels of need. As I mentioned, because the CHW is from the community, it is more likely for individuals to approach them and ask for help. This can be due to language barriers, fear of being misinterpreted, or because they just don't trust individuals. Next slide, please. Oh, yes, there it is, offering resources. Aside from providing educational material, aside from providing support, the CHWs can also go ahead and assist with providing resources. They can either mention transportation that might be available. This can be transportation from their homes to the work. This could also be maybe the CHW going out to the field and providing that assistance to them right then and there. They could also assist with referrals, increasing collaboration with other agencies serving that migrant population. They also can help with the lack of information for healthcare. They can go ahead and encourage individuals or help individuals find that healthcare coverage. They can also inform individuals of their rights and their OSHA complaints. As we also heard earlier, sometimes these individuals do not know what their rights are. And this is where CHW can go ahead and come in and explain to them, hey, you know what, you do have the right to take some break and to nurse that injury that you have. And the last thing that they can go ahead and do is point them to other resources, any other resources, whether it be food services, maybe financial services, housing services, et cetera, et cetera. Next slide, please. This right here is a guideline that has been created by MHP Salud. The purpose of this guideline of this document itself is to provide education sessions on mental health topics such as stress, domestic violence, substance abuse, and the relationship between chronic disease and mental health. Salud para Todos, which is the name of this guideline, helps improve communities by addressing the stigmas around mental health and encouraging the community to be accepting of those with emotional challenges. MHP Salud resources are culturally and linguistically responsive, easy to use, and created specifically for the community health worker programs operating with isolated and underserved communities. Materials are free to download with registration, and I have the link right there in case you guys are interested. So this guide itself provides you information as to how to culturally prepare material for those communities that you're assisting. Next slide, please. And here we go ahead and provide you guys with more resources. The first resource that we mentioned is from the Southern Eastern Coastal Center for Agriculture, Health, and Safety. This resource provides opioid abuse training and educational resources. We also have the SAMHSA national hotline, and this is a hotline that's free and confidential, 24/7, 365 days, and they provide that assistance in English and Spanish. I also have the AAFP Chronic Pain Management Toolkit. This is a chronic pain management toolkit. Is broken into sections to help you address specific gaps in your practice flow, standardized evaluation and treatment, and discuss pain management goals and identify those at-risk high patients. I also provided you guys with the HHS help and resource. This site provides with facts, data, reading material on prevention, treatment, and recovery. I also provided, we also found a comic, an online guideline that gives as comic style guides for preventing muscle injuries at work. I also provided here the CDC handout, which has guidelines, infographics, and also had podcasts. And that should be it. The next slide, please. All right, and then we through the survey that we went ahead and provided, we ended up finding out some of the needs that the health centers requested, which was more patient education material, tips to alleviate chronic pain, more service brochures, education on targeting stigmas, something to help track and log opioid cases in waiting rooms. Next slide, please. And that is it. We have 1 minute for questions. sorry, guys.
Yeah, feel free to put questions in the chat as we wrap up. I'd like to take a moment to draw everyone's attention to the chat box where we just posted the evaluation survey for this session. Remember to visit our virtual booth and give our sponsors a big thank you for supporting this amazing conference. Thank you, Mayra, Hansel, Patty, and Laszlo for this great conference.
Thank you guys for having us.
Thank you. Yeah.
Thank you.
I cannot write.